Hello, everyone. Thank you for joining. So we are going to go through posterior uveitis today. So we're going to look at a bit about intermediate uveitis and sort of pan uveitis. And we're specifically looking at that in the context of systemic disease. So I've done a session on infectious uveitis. I've done some stuff on anterior uveitis and sort of like your, seronegative polyarthropathies. And we'll also do a future session on things like the white dot syndromes and the miscellaneous stuff. But today we're going to focus mainly on systemic disease and how that can present with a sort of intermediate uveitis slash pan uveitis in the eye. So, starting off with intermediate uveitis is essentially inflammation of your ciliary body and vitreous. And just as a subset of intermediate uveitis, there's something called pars planitis, where you have features of the intermediate uveitis, which we'll go through in a moment. You get the snow banking, but pars planitis specifically refers to this subset that has no identifiable cause. So there's no underlying systemic disease, there's no infection that can be found. And it's a very specific diagnosis. Whereas the features of intermediate uveitis are, so you can sort of think about it as your sort of symptom signs and some complications. So the main symptoms that patients with intermediate uveitis actually present with is usually actually it's visual symptoms. So it's things like floaters, potentially a reduced acuity. But it also importantly tends to not be as painful as something like an anterior uveitis, and that's because your iris isn't involved. The pain from a uveitis tends to come from the contraction of the muscles of your iris. So with an intermediate or posterior uveitis, a lot of the time these patients are not necessarily actually in a lot of pain, but they complain instead of floaters and sometimes reduced acuity. And that might be because of the floaters themselves, or it might be because they might have some CMO related to it. Then, in terms of the signs, you'll see a vitritis. You might see some anterior inflammation, but usually with pars planitis, it's typically actually quite minimal. So, in a sort of idiopathic intermediate uveitis or pars planitis, you don't get a lot of anterior uveitis. Whereas when it's in the context of a systemic disease or potentially an infection, you will get that anterior inflammation. You may also have a bit of snowbanking, or some snowballing, which you can see peripherally on the retina as well. And then you potentially might even see some complications. So these are ischemic eyes. You can get neovascularization, you can get an ERM forming, potentially a cataract, secondary to either the inflammation or steroid use. They can have high pressures, they can come in with glaucoma. And these sort of types of posterior uveitis can also cause intermediate and posterior uveitis can cause retinal detachment as well. So specifically looking at idiopathic intermediate uveitis, this is essentially a diagnosis of exclusion. So you're going to investigate for everything. So you'll look for your inflammatory markers. You will send off things related to potential causes, your infective screens, your inflammatory screens, looking at things like TB, sarcoid, multiple sclerosis, for example. And then you're essentially going to manage the inflammation, and that can is going to be directed either locally to the eye or more systemically. So locally, you'll start off with some topical steroids, but topical steroids sometimes don't reach the posterior cavity very well. So you might want something that's a bit more either systemic or a bit stronger. So things like periocular steroids, like the orbital floor triamcinolone, maybe some subtenon triamcinolone, or just intravitreally with some steroid implants. Cryotherapy to the pars plana seems to work quite well. We're not entirely sure why, but that sometimes works well, as does laser. And then you can also sometimes do a vitrectomy as well, which releases some of that inflammatory load. And then systemically, sometimes these patients need systemic treatment because the topical treatment isn't enough. So they might be started on a steroid regime, maybe some NSAIDs or even some immunomodulation. So the bulk of today's session will be looking at systemic conditions which present with inflammation in the eye. So we're going to look at VKH, Sarcoid, and Behçet's today. And I'm also going to make a quick comment on sympathetic ophthalmia at the end as well, because it's not quite a systemic condition, but there are things to bear in mind that are related with the intermediate and the sort of panuveitis theme today. So with VKH, this is a disease of sort of melanocyte containing tissues. So you're mainly looking at things like your CNS, your eye, and sometimes your skin as well. So The main associations you're looking at, it tends to be Hispanic communities, potentially Japanese communities. There's a strong association with DR1 and DR4. And it comes in four main phases, which is your prodromal, then the acute uveitic phase, which is where sometimes most patients are actually going to present, and then the convalescent phase, and then your chronic phase. And when you're looking at these phases, the prodrome tends to be things like tinnitus, maybe some headaches, but in more serious versions where you're actually getting involvement of your CNS, you can even get cranial nerve palsies, encephalopathy, but that tends to be quite rare. So most of the time it's symptoms of tinnitus and headaches, which is why patients may not necessarily present, but when you question them when they're presenting in the acute uveitic stage, they may actually admit to those symptoms. The acute uveitis stage, it tends to be when they present. So it will be things like you'll have a bilateral granulomatous panuveitis. So you're going to be looking at things like maybe a papillitis as well, some exudative retinal detachment. After the acute uveitis phase, they then tend to move on to a more convalescent phase. So this will be where you might start to find the skin symptoms taking place. So things like alopecia, poliosis, maybe some vitiligo. And then after they move on from the convalescent phase, they then go into this kind of chronic phase where they get recurrence of their ocular inflammation, and then they might need to be managed a bit more closely, or sort of recurrently for ocular inflammation. You'll tend to investigate it, A, by looking for other causes. So things like lumbar punctures, you might want to do an autofluorescence, an FFA, an ICG, you might want to do an OCTA to look for any CNVs, and an ultrasound as well. And you might find some choroidal thickening on some ultrasound. And these are patients that are going to be treated with high dose steroids. They can be pulsed if they have severe disease. Otherwise, you're going to start them on an oral dose of about 1 to 2 milligrams per kilogram, taper them down quite long over 3 to 6 months. You might think about using some other immunosuppression. So sometimes some steroid sparing agents can be used quite early, actually, in managing the disease with VKH. And if they're presenting in the chronic phase with anterior uveitis, you're going to just treat that the way you do with any other anterior inflammation. What you can see here on the right-hand side are essentially the sort of diagnostic criteria for VKH. So if you have all five, you essentially have VKH. So importantly, there is an absence of penetrating ocular trauma because VKH can look very similar to sympathetic ophthalmia, but very importantly, there will be no history of any penetrating ocular trauma. There won't be any intraocular surgery, for example. There's no other disease. They importantly have a bilateral uveitis. They may have some neurological and auditory manifestations, and then they may also then get these manifestations of the skin. So if they have all five, they have what we call complete VKH. If they have 1 through to 3, and then they have either 4 or 5, they have what we call a partial VKH. And if they only have the first three, you might want to just make sure that you're not looking at any other diseases. But for VKH to be VKH, these are the five sort of diagnostic criteria that you need. So no history of penetrating ocular trauma, no other ocular diseases, a bilateral uveitis, the neurological manifestations, and then also the skin findings as well. Moving on to sarcoid. Sarcoid, nobody really knows where it comes from. It's a multi-system disease and it can essentially affect any organ. And you get these non-caseating granulomas. It typically affects the lungs, but it can affect any organ system. And the systemic features that you're going to get will depend on what system it's affected. So typically, if it's affecting the lungs, you might get a chronic cough, a shortness of breath, maybe some pulmonary fibrosis as well in the later stages. They may end up with they may presenting, they present with a rash, erythema nodosum. You can have cardiac arrhythmia, sudden cardiac death, and it can even involve the meninges and maybe even potentially a cranial nerve palsy as well. So these are the sort of rarer manifestations. It typically is a respiratory disease. In the eye, importantly, you have what we call a granulomatous anterior uveitis. Now, whenever I come across granulomatous versus non-granulomatous, I always wondering like, how do you actually differentiate between the two? So just a quick comment on differentiating between granulomatous and non-granulomatous uveitis. It's clinically that you're looking at it in terms of what it looks like. So with granulomatous, it's typically the sort of large KPs. It tends to be less painful. Whereas your non-granulomatous is where you get the much more fine KPs, and this is typically the more painful sort of red disease that you come across in terms of your sort of idiopathic anterior uveitis, your HLA-B27 uveitis. This is what your typical non-granulomatous, and that tends to be more ocular. Whereas with granulomatous disease, that tends to be more to do with a systemic problem, and things with like large KPs. So that's just a quick comment on how to differentiate between these two, clinically, which is important because then that will give you a different set of differentials. So back to the ocular sarcoid. So you're looking at mutton fat KPs. You might have some iris nodules, maybe even trabecular meshwork nodules. And then you might even find things in the posterior segment as well. So vitritis, some snowballing. You may have an associated multifocal choroiditis, which we'll go through at a later date when we're talking about the white dot syndromes. You may even just see granulomas. The optic nerve can be evolved again with granulomas, maybe some optic disc swelling, some disc edema or a papillitis. And then also the ocular sarcoid can affect other tissues around the eye. So you can have lacrimal gland involvement, which leads to dryness of the eyes. The conjunctiva can be involved. You can get granulomas in the orbit. So there's lots of different ways that sarcoid can actually present ocularly. Um, when you want to investigate sarcoid, so you've got the blood test that you'll do, your full blood count, your inflammatory markers, your liver functions can be abnormal. You're going to want to send off a serum ACE. Their calcium can be high. These are patients that would benefit from a chest X-ray. You might see some hilar lymphadenopathy. They'll get some CTs. They'll get a bronchoscopy. This is all be done with respiratory medicine. They may have a biopsy done of any kind of caseating, non-caseated granulomas of the lung, and then obviously they're going to be followed up chronically with lung functions if their lungs are involved. But for us, in terms of from an ophthalmological point of view, if you're considering sarcoid, you'll probably want to send off some bloods, looking at some serum ACE and some calcium. And you're also probably going to want to do a chest X-ray as well, at least as a baseline before then deciding whether or not you want to involve your respiratory colleagues. Sarcoid is managed with an MDT. So your respiratory physicians are going to manage mainly the sort of systemic disease. But for us, from an ocular point of view, you're going to essentially treat it in a stepwise manner as you would with any ocular inflammation. So starting off with topical treatment, working all the way up to orbital or intravitreal steroids, potentially even systemic steroids if the inflammation is not controlled. And then you're going to want to treat for complications as well. So if CNV comes out, they may be treated with anti-VEGFs or some laser. Cataracts would need to be taken out. The glaucoma may need to be managed. These are patients with inflammation. They may develop CMO, and in the same way, you're going to try and manage those as well. So it's chronic management and systemic management that's really important with the sarcoid. Moving on to Behçet's, finally, in terms of the three systemic diseases that we were looking at today. So Behçet's is typically characterized with oral ulcers, genital ulcers, and uveitis. And its underlying pathology is understood to be a vasculitis all the way from small to large vessel. And this is why Behçet's can sometimes be fatal, because if you have a vasculitis that involves the cardiovascular or the central nervous system, you can end up with things like strokes, heart attacks, and this can be the mortality of the patients can be high from that point of view. And there's involvement in about 5 to 10% of patients in terms of these more serious side effects of Behçet's. Your main risk factors, so you're looking at sort of the Mediterranean, Turkish, Middle Eastern populations. Potentially, there's a small subset of a population in the Far East as well, and it's quite strongly associated with HLA-B51. In terms of your sort of predisposition from a gender point of view, that depends on the race that you've come from. Um, there is a diagnostic criteria again. So specifically, it's a patient who's had an oral ulcer 3 times within a year, alongside at least two of either genital ulceration, ocular inflammation, typical skin lesions of Behçet's, things like erythema nodosum or pseudofolliculitis, and a positive pathogen test. So they need at least two of those alongside 3 ulcers within 12 months in the mouth for them to be diagnosed with Behçet's. And while the ocular manifestations tend to be the presenting complaint in about maybe only 10% of patients with Behçet's, up to 70% of patients with Behçet's will have ocular symptoms at some point. It just doesn't tend to necessarily be the most typical presenting feature, but it's definitely a feature that they need chronic uh, review for. So ocular Behçet's, it's almost always bilateral, and if it's not at presentation, it will end up affecting both eyes at some point. But it does tend to be self-limiting, so it tends to run its course and then fizzle out. And visual prognosis tends to depend on involvement of the retina, specifically with an occlusive vasculitis. So while it typically presents with an anterior inflammation, this will be non-granulomatous. So you're going to have the fine KPs. It will be your typical sort of painful red uveitis. You may find, in your SBAs when you're in your exams, you may come across this sort of idea of a mobile hypopion, and it will almost always be bilateral. They may have a vitritis. The retina can be involved, either with a retinitis that doesn't leave any scarring behind once it settles down, but they can also have a vasculitis. It can affect both the arteries and the veins, and that can then cause occlusive vasculitis, so things like CRVO, CRAO, and that tends to be where the vision loss comes in with ocular Behçet's. It tends to be if an occlusive vasculitis has happened. And then the optic nerve can be involved as well. So again, with edema, maybe some hyperemia and neovascularization with chronic edema as well. You'll investigate with, again, an inflammatory screen, sometimes a thrombophilia screen, because there are other causes of the phlebitis that you might be seeing in the eye, HLA-B51. You might want to do an OCT, some autofluorescence and an FFA, again, ruling out other potential causes. And sometimes you might want to consider, again, looking for other causes. So you might want to biopsy the lesions, and that will kind of confirm Behçet's. Or you might want to look, if you're looking at kind of, if it's been mainly CNS involvement, you may want to kind of, the medics may want to do some neuroimaging and lumbar puncture just again to rule out some other causes. The management of ocular Behçet's. So by managing the Behçet's, a lot of the time you manage the ocular manifestations. So these are patients that are going to need systemic immunosuppression, but locally, depending on the inflammation, again, you might give some topical steroids and then the stepwise management of ocular inflammation. But Behçet's requires systemic management, and usually when you manage it systemically, a bit like you do with IBD and your other seronegative arthropathies, you tend to manage the ocular disease. So these are patients who are going to get steroids in the acute setting, maybe some azathioprine, cyclosporin, or infliximab, and you're going to work up your immunosuppression depending on what the patient needs. So finally, like I said, I wanted to make a comment on sympathetic ophthalmia. So this is also a bilateral granulomatous panuveitis, but this is usually in the context of trauma. So it can look very similar to VKH, but these are patients who may elicit from them a history of a penetrating trauma or maybe even some intraocular surgery. And it tends to present within the first 3 months, but it can present at any point in life after penetrating trauma. So, like I said, in the history, you may elicit some history of trauma or intraocular surgery, very rarely. And then your examinations, it will look very similar to something like a VKH. So, in the anterior segment, you'll see a granulomatous uveitis, maybe a hyperemia, and then you might see some choroidal infiltrates, chorioretinal scarring, exudate, and serous subretinal fluid as well. You'll want to investigate with all your ocular sort of investigations, but mainly the management of this. So some reports have shown that if you have an offending eye and you enucleate it within the first couple of weeks, or eviscerate with complete removal of your uvea, that usually has quite a good outcome in terms of managing the sympathetic ophthalmia in the other eye. Otherwise, these are patients who are going to need high dose steroids to try and manage this sympathetic ophthalmia because it can be quite detrimental to the vision. And these are patients that usually already have lost the other eye. So you're dealing with an only eye and you really need to get on top of that inflammation very quickly. So systemic high dose steroids, potentially even pulsing them. And then you're also going to bolster that locally with topical steroids, maybe some intravitreals as well to the eye itself. And these are patients that are going to need long-term follow-up because they can recur. And sometimes that recurrence can happen years down the line. It doesn't necessarily have to happen straight away. So just to summarize, we've spoken about the sort of systemic associations of a posterior uveitis and panuveitis. So looking at VKH, Behçet's and Sarcoid. And we just commented very quickly on the differences between granulomatous and non-granulomatous uveitis. And then finally, we just finished off with just talking about sympathetic ophthalmia and differences between that and VKH. And really, the takeaway with that is just making sure you're eliciting the history of trauma and patients who have had globe traumas, patients who have had uvea exposed. To the environment, that tends to be the understanding of the underlying pathology of sympathetic ophthalmia. So these are patients who are going to be at risk of developing that at some point in their life. Thank you for joining. Please do remember to fill out the feedback. Thank you very much again, and we'll see you at the next one, where we'll talk about in this series at least for the next time I come back to uveitis. We'll be covering things like white dot syndromes and the differences between them.